Hi, welcome everybody. Such a great pleasure to have these very good friends from the United States on Endoscopy On Air. John, Stavros, welcome on Endoscopy On Air. This is our house. They will be your place as well. So thanks for joining us. So connectivity series is a nice way to talk each other and to discuss about innovation in endoscopy. John, I hope you don't mind. I will ask Stavros to introduce himself first, and afterwards you will introduce yourself. Because I have no words to introduce Stavros. It's too big to me. So Stavros, introduce yourself. Please.
Well, it's not a good idea to let me introduce myself.
Why not?
But anyway, I am in Mineola, New York, for the last 14 years at this hospital called Winthrop. Now it's called NYU Long Island because we merged with NYU. And, I did the first poem in the US. I started DSD in 2005. The first poem was in 2009, EFTR 2012. I always pioneered these resection procedures because I was looking for something more interesting than ERCP after doing a few thousand. So, and the rest is history. I'm now 80 to 90% of my practice is POEM, ESD, and other third space and notes procedures. So I always feel glad to talk about these procedures, especially with such distinguished friends like Alessandro, a pioneer in Europe, and John Day, who was there at my very first steps in the pig lab of Winthrop University Hospital back in 2010 when we're doing, POEM and ESD in pigs. That's a great pleasure. Thank you.
John, and now it's your time.
Oh, thank you. Yes, Stavros, I remember those days. So I've been in the medical device field since 1986, before you and Stavros were born, Alessandro.
Oh, no.
And it was fortunate. I got to see the whole transition from open surgery to laparoscopic, minimally invasive procedures. I've been with Erbe the past 22 years, 20 of those as vice president of marketing. And prior to that was with Covidian Valley Lab. So the energy space is near and dear to my heart, and very happy to be here. Thanks for inviting me.
Okay, thank you both. John, when you met the first time Stavros, what was your first feeling? So I'm curious.
Well, I was intrigued.
Be honest, you need to be honest.
I was intrigued. I have funny stories around that, but
yeah.
When my rep called me and said, "This is what we're doing today at Stavros's first poem," I said, "Mike, get in your car and drive away." And that's a true story.
That was the first human poem, right?
That's right.
And the John's like, "Who's that guy Stavropoulos? I know Frank Gress in Long Island. Who's Stavropoulos? Anyway, get in the car and leave."
That's a very funny story. Okay, so Stavros, I want to start this quick talk with both of you, just with a very sincere congratulations. I read your paper, recent paper accepted on GI endoscopy. I think this is a landmark piece of endoscopic science in poem. Huge series, very detailed description of what's happening, how you, I think you matured your experience, how you managed the complications, even though they were very low. What were the clinical results, technical results? So sincere congratulations. Can you tell us, so you say the first was many years ago. How did it come along all these years? What's happening to your experience in poem? That's very important to us.
Well, when we started, we were doing very short myotomies. Inui, his first cases were 3 to 5 centimeters. So that's where we started. Then we all got, I think, very aggressive. We got to 11, 12 centimeters. And then we realized that's too much. And now over the last 3, 4, 5 years, I'm down to 5, 6, 7 centimeters. That was one difference. Obviously, you get faster. My procedure time went from about 2 hours when I started average procedure time to now, I think something like 40 minutes in the last 100 cases. So you get faster. And then the other thing is, obviously, everybody's bothered by reflux, even though that's an expected side effect of opening the sphincter. So we tweaked that. We did a randomized study anterior-posterior. It didn't show any difference. And then after that finished in 2018, we were intrigued by by preserving the oblique fibers using landmarks like the Tanaka vessels. For the last 3 years, we have been doing this, what we call the anti-reflux poem, by specifically preserving the oblique fibers. So this is our newest thing, and we presented a case control study with propensity score matching last year's DDW of 116 anti-reflux poems matched exactly with 116 conventional ones from the immediate previous period, like just before 2018. We do about 100 poems a year, so there's plenty of research material. And we showed a 43% reduction in reflux. We went from 70% pH positive to 40% pH positive in this case control study. We're collecting now reflux data. We had 60% tested in each group. We want to get to 80% tested before we send the publication out. So this is our newest thing in POEM. It's the anti-reflux one, which dramatically cut the reflux. So as it turns out, it's not just about anterior-posterior. It's anterior with avoidance of the oblique fibers or posterior with avoidance of oblique fibers. If you don't take care to do that, you can damage them even on an anterior poem if you go towards 11 o'clock, and you can damage them posteriorly if you go to 5, 6 o'clock. So this is our newest, hottest thing on poem right now.
Stavros, it's very nice to know that you work in that space. My curiosity is how difficult it is to identify oblique fibers when you are distal down in the very narrow part of the distal esophagus close to the stomach. What is a technical tip that you can give us to identify properly the oblique fibers and to leave them untouched?
You can use the Tanaka vessels, and you can use basically the direction of the fibers. Once you start seeing them, then you can recognize them easier. To be honest, now about half the time I know where to go, so I don't even expose them. I mean, there's no, in the beginning I would find them and then try to avoid them, but it's even better to go to the right of them enough where you don't even expose them. And that's what we do maybe half the time. The other half of the time, you end up in a position where you do find them in front of you, and you have to adjust your course to stay to the right side of them. One of the videos on this 6-minute video, I show coagulation of the Tanaka vessels, those arteries that are one of the landmarks that identify the oblique fiber. So you can actually, when we show that part of the video, you can actually see the oblique fibers and then the Tanaka vessels and then the circular fibers. So we can review it on the video. Okay, we will review afterwards. So, John, I think Stavros started with the hybrid knife technology. Is that correct? First the poem?
He actually started with biliary balloons when he first started out, and then he rapidly, I think, adjusted to the hybrid knives. How many cases, Stavros, after using those biliary balloons?
I used a blunt CRE balloon inserted and inflated to make the tunnel on the first poem, which is actually a case report in GIE in 2010. I didn't call it poem because the term didn't exist. I called it myotomy for achalasia using submucosal endoscopy with mucosal flap, SEMF, which is what Gostaud used to call it.
Yeah, reported in GI endoscopy with Leeds Ryan in 2007, probably in an animal study. That's correct.
Right. So I called it that. So some people cannot find it, but we had our first case report of a poem in 2010 in GIE, which was at the same time as Inoui's first publication of the 17 patients. But if you see that, it has a video. The whole tunnel was made with
a
making
blunt
a
balloon.
small incision in the mucosa, sticking the balloon, inflating, then getting to the end of those 5 centimeters, sticking the balloon, inflating. That's obviously dangerous, this blunt insertion of the balloon in the submucosa, which I had pre-injected using the Erbe jet. But anyway, obviously we gave up on poem 3 because the balloon split the muscle. I'm like, this is dangerous. We gave up on that. So after that was dissection. We used the TT knife until poem number 17. From poem like 5 to 17 was the TT knife. And then from poem 18 to now at Winthrop, 790, but globally maybe 900, we have used the hybrid knife. So after poem 17, we have used the hybrid knife. The I-type, not the T-type that most people use, the I-type, which is a little more precise in dissection.
Okay, John, what is the situation in the United States? So what is the number of poems performed with the hybrid knife technology? What do you think?
If I had to guess, I would say it's probably 60% are performed with hybrid knife. Maybe more. I'm being conservative. Yeah, I'm being conservative.
And most of them are using the I-type or the T-type? Because here
It's
in
split.
Europe, it's T-type.
It's interesting. It's split. The ones that are still doing anterior approaches tend to favor the T-type. Many have gone posterior and they find the I-type more precise. So it's, but it's still split, I would say.
Okay, so very as little curiosity. So you think that from a physical standpoint, from the physics of hemostasis, having the T-type can afford better hemostatic pressure on the vessels, or doesn't matter? John?
I think it has to do with more surface area. So it's more hemostatic. I think it's more hemostatic, the T-type. But of course, there's a little bit greater risk depending on the operator of thermal insult in the poem procedure, for instance, to the mucosa. In ESD, there might be a little more risk, arguably, of damage to specimen and creating a non-RO resection.
Okay, Stavros, since your first poem, I think you changed at least two different series of generators, and now you are using VIO3, I suppose. Is that correct?
Yes. No, I think the first poem, you think, John, I think it was VIO 300, no?
It was.
In October 2 of 2009. So I just had VIO 300 from the beginning. And then we switched to VIO 3 a year and a half ago. When did we get it in Winthrop?
About a year ago, I think. Maybe a year and a few months.
Well,
but yeah,
as soon as it was FDA approved, right?
Yes, pretty soon after that.
So the VIO3 offers a huge variety of selection of combination of coagulation, cut. You can adjust very precisely what you want to obtain on the tissue. So and now I think the big new in electrosurgery is the PreciseSECT modality. There is a lot of discussion on PreciseSECT. I know that you are developing some concept about PreciseSECT. Stavros, can you tell us about PreciseSECT? If you have a presentation, please go on with your presentation.
Yes, I have just 4 slides of some electrosurgical principles, and then more importantly, 6 minutes of video in different scenarios, veins, arteries, muscle, that we can discuss. So let me show you the PowerPoint.
I can see it.
PreciseSECT is a new current that is not available on VIO 300, and it's available on VIO 3. And, what it does is it takes advantage of the amazing microprocessor that the VIO 3 has that can calculate 25 million times per second the tissue resistance or the impedance, and then adjust the power delivery to achieve the desired effect. And I'll show you what this effect might be. So let's say you are dissecting nice saline-infused, very conductive submucosa, mixed in with a little, very thin veins. Then you do the classic dissection technique with the tip of the knife to make sure that you have high current density. It's really a low impedance. Once the spark gets generated, you get a little plasma from ionized air that creates a very low resistance conduit to the tissue. And even with non-touch technique, there's a low impedance going on there. So the PreciseSECT delivers essentially a cutting current, or what looks to the clinician as a cutting current, very similar to dry cut. It's the complete sine wave with peak voltage over 200 to achieve this acoustic wave and vaporization of tissue, but less than, say, 1,000, where you start getting thermal effects. And you get these little white-yellow microarcs, nearly invisible, that are consistent with this plasma formation at the tip of the knife with very high current density. Okay, so this is the tissue vaporization. Then if you get to an artery, I don't know why it's doing that. If you get to an artery, what happens here is you start desiccating the muscular wall of the artery. And as you see, we use a big contact with the knife to decrease the current density, because even coagulation current will cut if you increase the current density to a high enough density. So you need low current density. You use the flat part of the knife to slowly desiccate and then coagulate the arterial wall. The minute it starts desiccating and whitening, you get really high impedance. And what you get from PreciseSECT is a coagulation current, maybe similar to forced coagulation. You have these bursts of modulated sine wave with higher voltage, where and that creates increased temperatures that coagulate the tissue, and you get a somewhat different spark. It's this yellow, orange-yellow, brass-like, fatter spark than what you get on the precise cutting. And this intermittent burst of current and high tissue impedance basically slow cook the tissue, and the idea is to coagulate the vessel before you cut it, so you don't get a bleed. And then finally, obviously, you should do this for maybe 1 millimeter arteries. And even then, you may need to decrease the effect on the precise from 4 to 5, which is 70 watts, to 1 or so, which is 15 watts, to make sure you don't accidentally cut even with the side of the knife before the vessel is coagulated. If you get to 2 millimeters arteries, obviously you should use the coag raspberry. This technique, it has a significant percentage of time where you will end up cutting before the coagulation is complete, because of the thickness and the very low, very high impedance that you get once the tissue starts cooking. I'll show you this on the video. Now, interestingly, you can use it on a poem myotomy. And where would I use it? I mean, normally I use the typical endo cut or dry cut with a little bit of spray. But when would you use a PreciseSECT on a myotomy? The pull technique. If you're in the EG junction with a very tight sphincter and the mucosa is very close to the muscle, instead of pushing the scope forward and picking the fibers and lifting them and cutting them, when you could hit the mucosa, you could do the pull technique, starting the cardia, and as you withdraw the scope, cut downwards towards the mediastinum. The problem with that, if you use a cutting current, you can zipper right through the muscle and hit the diaphragm, or even worse, maybe lung, aorta, the heart. So you don't want a zipper cut. I borrowed this term from ERCP, sphincterotomy. You want a more controlled cut. So, the precise cut could deliver that, because it's really high impedance, and it delivers a bit of a coagulating cutting current. And the only way you achieve cutting is by using the tip of the knife and high current density. So you have a coagulation type current with high impedance as the muscle cooks, but using the tip of the knife, you can cut because you concentrate all this coagulation energy to a very small amount of tissue. So that's what you get. And the other time when we use that is when you cut with a pull technique, you lift the fibers to cut them. Sometimes the muscle has all these transverse vessels in it, right and left, like a ladder, and you want to cut with a coagulating kind of current. So this works. You basically get hemostatic cutting. And that's where I would use it. And now, if you want, we can see all this demonstrated on the video.
You want to show the video now?
Okay. It's a 6-minute video that has all these scenarios.
Yeah.
Let me see. Where's QuickTime? Here. Got it? Yeah. Okay. Wait. Okay, so you can see the video?
Yeah.
Okay, so this we'll begin with a basically what is a 1 millimeter or so vein in a poem. You can see that a vein has very similar electrical characteristics to the saline diffuse submucosa. It's really a very thin-walled bag of blood. So it doesn't offer very high impedance. So once the spark starts, you can just zip slowly through it without even stopping. Very effectively. See, it's like the regular submucosa. Having said that, there's so little thermal injury that I am somewhat concerned here. So I would do a little bit of touch-up using the tip of the knife. You can see at the bottom we did get slight attempt at bleeding, and then you can whiten it up a little just for safety here. So that's really vein, and that's a 1 millimeter vein. It's a sizable vein. This is other veins, same concept. Very easy to coagulate them as if it was regular submucosa. And then you get to a small artery, a sub-millimeter artery. You can see the whitening of the muscular wall. So this is a little less cutting current, but still a very small artery. As long as you move slowly, PreciseSECT takes care of it without even stopping. Now you get a bundle of arteries. You can see the elasticity of the arteries and the lack of compressibility. And as you cut, you get a tiny tip of bleed, but still very quick cutting with PreciseSECT. Now these are the Tanaka vessels. If you want, I can pause here. Well, these are 1 millimeter arteries. So here you have to go really slow, and you see how it became white first, and then it cut, but at the bottom, it didn't coagulate fully. And it's important not to stretch the artery too much, because then it may end up ripping earlier than the point of coagulation.
Stavros,
So
can you show again this? Can you show again this?
Let me go back and show it, and maybe I can show the oblique. So I took care of it with Precise. You can see the oblique here.
Yeah.
Juxtaposed next to the circular, but let me go back and maybe show it a little better. Let me go to the beginning.
Okay.
So you see here the oblique muscle, right?
Yeah.
The bundle that starts somewhere behind the knife and ends right here. You see this edge? I don't know if you can see my mouse. Probably not, right?
Yeah, I can see it. I can see it.
So this is the edge, and the edge of the oblique is right where the Tanaka vessels penetrate. So this is circular. You can see it's perpendicular to the tunnel. And this is the oblique running parallel to the tunnel. You can see it.
Yeah.
At 7 o'clock, maybe.
Yeah, we can see it. Yeah.
You can see the tip of the hybrid knife is 0.7 millimeters. The knife itself, not the catheter. The knife is 0.7 millimeters. So these two arteries that are penetrating, you can see each one could be easily about 1 millimeter. So you have to be careful with those. I think as a beginner, you may still want to use the coag grasper. But see, you go slowly. You don't tent the arteries too much. And you use the whole knife to bring the current density very low. And then PreciseSECT senses the impedance as they're cooking. Did you see what I did here? To increase to lower the current density even more, not only did I use the whole knife, but I sucked so that this V of muscle touches the knife almost circumferentially to lower the current density even more, to be able to coagulate the edge of the arteries over there without much injury. And now I finished the tunnel here. You can see again the obliques left, the circular right. The upper part of the Tanaka vessel is bleeding now. That's dangerous because it's under the mucosa. So you need to pre-inject, puff it up to protect the mucosa. But again, I'm using PreciseSECT by tamponading the tip of the vessel with a knife to eliminate blood flow, which has a heat sink effect and coagulate. Now this is rectal ESD. That's where you get really big vessels, pulsating artery surrounded by 2 or 3 veins. Again, at least 1 millimeter artery penetrating the rectal wall. And the most vascular areas are basically the EGJ and the rectum in ESD. So here's the rectum, big bundle. Again, I use the entire knife and coagulate slowly. Now the impedance will go really high now because you have a coagulated bundle, but see how the veins shriveled immediately. But you still have, the artery is still alive. I'll show you. It has a very strong elastic wall. You can see it's even pink a little bit. So if you cut it now with cutting current, it's gonna bleed still. So you use more precise and you still have a live wall for the artery. It's still there. So now again with PreciseSECT, slow cooking. So we can coagulate it before we cut it, and still there. And finally it's cut. So it needs a little precision and patience. That's in the same rectal DSD, another bundle. Again, pulsating artery surrounded by 2 or 3 veins. You can see how compressible the veins are. The knife is easily compressing the flow on this vein. And look at this stretchy vein here, very regular shape, easily compressible, but not the artery. We do NBI for fun here. I'm not sure what I was doing, but anyway, we are going to now start slight compression, but not too much. But see, I have very little knife. I only have half a knife. That's not good.
It looks like you are underwater.
I do underwater sometimes to get nice pictures, like magnification,
okay.
But now it's not underwater.
Okay.
You don't want to coagulate underwater. So I start coagulating with the entire knife.
And you're sucking to...
Yes, to surround the knife.
The surface.
And then I now go from the other side, cook it from here, cook, slow cooking. I don't press too much mechanically, because again, I don't want to rip the artery before it's done. And now it's basically done, but then again, you do get a little escape there near the muscle. So again, you tamponade the bleeding with the tip of the knife, and little PreciseSECT coagulation, takes care of that. And finally, the myotomy is see, this is pull myotomy. We pull backwards and we cut with precise so we don't get the accidental zipper that goes all the way to the mediastinum. So it's very slow, precise kind of cut. And you can see I get a little bit of this orange spark because there is a high impedance in this partially cooked muscle. But see, I can get to the longitudinal fibers without worrying that I will split them and cut through them, because the minute the impedance changes in the fascia between the circular and longitudinal fibers, there's almost like a slowdown of the current there. So you can very precisely find the proper depth. And you can see now the longitudinal fibers at the bottom of the incision. So it's very precise myotomy, especially when you do the pull cut, where you can accidentally zipper too deep. And the second part shows how to use it on a push myotomy in patients that have these hidden transverse vessels mixed in with a muscle, like there's one. So here, even though it's push, I will still use precise to slowly go through the muscle and the vessel. And then continue. There are more vessels that you see that are hiding in there, trying to trip us. See, there it is. There's another hidden vessel that you see right there that was waiting to cause trouble. But with PreciseSECT, even if you cut one of those hidden vessels, it will nicely, slowly coagulate it as you do the myotomy. So this is the other potential application in myotomy. when you push but have vessels, or when you pull at the EGJ. I think I can stop it here. I don't think there's anything else that is. I just continue using it the same way all the way to the bottom of the tunnel.
Yeah,
Okay.
so I understand you're trying to avoid the oblique fibers. You go away from the oblique fibers.
To the right of them, yep.
Okay. Okay, so there is a lot of combination of currents when you use a PreciseSECT. I think John can go in more technical details of this modality. So John, this is going to be used as a main modality for POEM in the United States. We are adopting full. So what about United States? Everybody is moving towards PreciseSECT, or is still premature?
It looks that way. Not everybody has Bio 3, obviously, but the ones that do are using PreciseSECT and
doing that
in their third space procedures. You can see my screen now, I assume.
Yeah.
They're using PreciseSECT because it is novel. It's something that the company has had in the vault, so to speak, for many years, an algorithm. And with the new digital processors and parallel processing and whatnot, has been able to do this high amount of analyses, 25 million cycles or analyses per second, to come up with a waveform, basically, that automatically shifts between dissection and hemostasis. Nothing is a panacea, but so far the adaptation rate has been extremely high and extremely successful. And the screen that I just pulled up, and I only have one slide or maybe two slides. This is courtesy of Dr. Neil Sharma in Fort Wayne. These are venous structures. They're not arteries. GEJ, and this mode operates on the same constant voltage output that a lot of the Erbe modes, endocut, dry cut, operate on. So power adjust automatically based on target tissue electrical impedance. In this case, Dr. Sharma has isolated this bifurcated venous structure, and it's probably a drainage vein that Dr. Maselli, your own Dr. Maselli, wrote about with Dr. Inouye on a paper back in 2017, I believe. But he isolates these venous structures first. And what you're going to see on the screen now is an oscilloscope. And this is the real difference in PreciseSECT that Stavros just very eloquently talked about, and the other Erbe modes that you guys are used to. And that is that when impedance is high, electrical impedance is high. So in this case, the knife, the hybrid knife, is not in contact with target tissue, and electrical impedance is high, so it's more of a dissection waveform. It's a dynamic adjustment of the modulation frequency. So the frequency is higher than if it was a very conductive surface. So you'll see as the knife is activated, it goes from a high impedance to a low impedance. So we come through into this venous structure with, obviously there's blood inside of it, very saline-rich blood flow. The key component of this being that the surface area of the knife has been increased, as Dr. Stavropoulos just showed. And with more contact or surface area, the impedance drops to very low, and we automatically, or the machine automatically, the waveform automatically adjusts to less modulation frequency, so it becomes more hemostatic. And this is all in the same pedal. So you're not shifting pedals, as you know, you're still working off the blue pedal. And then it goes back to high impedance. So the oscilloscope or the output, the modulation frequency changes.
Can I interrupt here for a second?
Sure.
Because I don't know if you realize, but we're telling them different things. So you're saying that, no, I want to see the video though, that you were showing. Because you say, so what are you saying here? That there's low impedance as you coagulate. So when the machine senses low impedance, meaning high conductivity, that's when it goes into a coagulating low duty current.
That's right.
Well, at least for the arteries, I'm saying a different thing. Like when you start coagulating the artery and it turns white and you have muscle, that's much higher impedance than this nice saline ethereal submucosa. And I see that orange spark comes, and I think that's what the machine is delivering coagulation low duty current. So I think what we're saying is slightly different.
It's really not. It's really not, Dr. Stavropoulos, because these variables change in milliseconds. As you begin cooking the artery that you showed on your video, the electrical impedance rises very rapidly. So it goes from a low frequency, a lower frequency, let's say, depending on the size of the artery and the amount of knife that you have in contact with the artery and the surrounding saline and the amount of tension that you have on the artery. So it goes from a hemostatic waveform or a low modulation frequency, and then as it becomes cooked and becomes more electrical impedant, then it automatically shifts on that same artery to high modulation frequency because it becomes dried out and higher in electrical impedance. And that's what you're seeing when you describe it as sort of an orange glow or an orange spark.
So everything is related to tissue impedance, no? Is that correct?
Totally. So tissue impedance.
What is the difference between impedance of submucosal tissue and vessels? Can you tell us, John?
Oh, I can't tell you. And actually ohms, because it's so dynamically changing. You have more or less saline in the submucosal space, or you've aspirated the saline out of the submucosal space and blown CO2. So you have that nice cobweb appearance. Then the impedance is very high, but it's rapidly changing based on the time.
This is the value of the software of the VIO 3 that adapts systematically to what is the difference in tissue impedance. Is that correct?
That's exactly right. And this mode in particular, which is at 25 million times per second, it's alternating between dissection and hemostasis.
Yeah, that would be an interesting study because I specifically tried to answer this question. So I went to PubMed and I started looking for resistance or electrical resistance or impedance of tissues in electrosurgery. And I could not. There is some studies looking at macroscopic surgery. So they look at liver versus muscle, but we want microscopic data on vessel at the beginning of coagulation, at the end of coagulation, submucosa, artery versus vein. So this would be a fantastic study because I don't think that this data exists.
No, Stavros, there is another factor that can influence tissue impedance, the fibrotic reaction. So if you have a lot of fibrosis, they may change significantly. It depends from esophagus to esophagus, dilated and not dilated. Inflammation as well. If you have a lot of food staying there for a long time, creating inflammation, this also may change the resistance of the tissue. So there are so many factors. And I think we have to rely on the machine. We cannot estimate ourselves. And also it's a very quick change from insufflation of CO2 to a lot of saline into the tissue because of the water jet. Probably the best is to rely on the software.
Right, we could get from the VIO 3 the data.
Yeah,
we could actually get the data and understand how submucosa injected, say, with orized gel, what's the conductivity? Submucosa injected with saline, what's the conductivity? Veins, large veins, small veins, big arteries, small arteries. All this data should be available through the VIO 3.
But Stavros, I agree with you. I mean, but the minute you step on that pedal, the impedance variables begin changing dynamically in microseconds as thermal insult to the surrounding tissues. So it's constantly adjusting, as Dr. Rapici referred to. This is the same patient, just a smaller venous bundle here. Less knife will be used, less power will be used. The voltage is the same, but and you can see the little pulsing venous bundle down here in the muscle. It's completely sealed off, but that's just another example of a variable. I mean, just a smaller vascular structure, less surface area of the knife. And in that case, there was no saline surrounding the knife. So I think Dr. Rapici's right. We have to rely on the machine at some point and just know that even the machine is not going to be 100%. Much of it, everything you guys do, by the way, is based on a lot, not everything. Don't get me wrong, because your paper was brilliant that Dr. Rapici referred to, but much of what you do with your approach to therapeutic endoscopy is based on your own experience and anecdote to some degree based on your own experience.
Okay, guys, a very interesting discussion, and I think there are so many things to be said about electrosurgery and third space endoscopy. So, Stavros, tough question to you. So, what do you like to be improved in a hybrid knife? What do you don't like, and what do you like to see change?
Well, really, very little. I mean, what I would like is for the knife catheter combination to have the flexibility of, say, a dual knife, more flexible. But this is really the main thing. I mean, making it shorter for colonic ESD and whatnot, would be useful, like a 3 millimeter knife instead of a 5 millimeter, but more flexibility, I think.
And also,
yeah, that's the main
a little bit
thing.
smaller to have more space, smaller size for more
Yeah,
space.
like a 3 millimeter knife. Yeah.
I think Erbe is going that direction. So we had the privilege to test on animals the new hybrid knife. I think, John, you know anything about the new hybrid knife?
I don't know specifics about it, but I do agree with everything you guys are saying. I think the electrode size probably could be smaller, especially in ESD. I'm not saying that for POEM, but for ESD, we need a smaller diameter electrode in the range of 400 to 500 microns, and the knife for colonic ESD in particular needs to be locked in place.
Yeah, everything you said is going to be realized with the new version of a hybrid knife. We have tested in animals just for ESD, because I think for tunneling, for POEM, the present hybrid knife works extremely well. We don't need big changes on that. We need to have a smaller, a little bit more different device especially for colorectal ESD, which is a more tough procedure. And the team at the Erbe into being, and they did a superb job. They made everything smaller, more round tip, and the final effect is very similar to the dual knife, but still with the capability of a water jet, which is impressive because they made everything smaller, shortened, but still we have the power of injecting with hydrojet technique. So probably for the future, we are going to use more and more this technology also for colorectal ESD, advanced tissue resection. So what you presently using, Stavros, for your colorectal ESD? You using dual knife?
For rectal, I use hybrid many times, or most times. It's sort of a pocket tunnel technique in the rectum if it's not in a difficult position. The colon, and 88% of my colorectal ESDs are actually colon. No, sorry, 90% are colon, and 88% of that is right colon. So you need a very flexible knife. So I was using, I do about 100 a year colonic, not rectal ESDs. It was all dual. Until the Pro knife came out. But now it's all Pro knife.
Okay.
The Boston Scientific. It's as flexible as the dual. The knife, very similar with the dual. And you can inject with very high efficiency through the tip of the knife, not through the side catheter port that the dual J has, which is not very efficient.
Yeah.
Right through the tip of the knife. You can inject, cut. It's it's a great knife. So I've switched it entirely from dual to prone knife on these 100 ESDs in the right column.
So probably in the near future, having the water jet technology available on a smaller knife, more rounded, shorter, that will be probably a very good combination to keep going with ESD in the right column, which is probably the most difficult space with to apply ESD technique as well as duodenum. You do duodenal ESD?
Yes.
So you
Same
have any
thing. I was dual, now prone knife with the orized gel. The problem with the prone knife, it's hard to inject with force.
Yeah.
That's why if Erbe has a similar knife that fits on the pump, that would be, amazing.
Okay. Okay, this is a great point. So you have such big experience with poem. Can you tell us what we should be scared of? The most dangerous complication, what's most tough situation, and how to manage it, please?
Well, I've heard of a death in the United States now, and there was a death in the Czech Republic, and there were 2 near deaths that were published. All 4 events were pericardial tamponade. So this, I think, is the most dangerous, potentially fatal event that can happen. Like 2 of them are arrested, but were CPR'd and were resuscitated. And this person in the Czech Republic and this person in New Jersey died. So, and that's the ones I know through the rumor network. There may be more that I'm not aware of, but all the severe complications I've heard, life-threatening or near fatal, were getting tamponade in the pericardium. Basically, you do an anterior poem, you nick the pericardial sac, you are too liberal with the CO2 insufflation, or you accidentally use the air, and then you get a capnopericardium causing tamponade and, cardiac arrest. I think that's the most dangerous complication. And avoiding it, I think, why do people do anterior poem? I think everybody should do posterior unless the anatomy requires anterior, unless this is a redo poem and the patient already had a posterior poem. But yeah, the anterior, if you can avoid anterior poem, or if you do an anterior poem, maybe not enter right behind the left atrium, where the left atrium is actually bulging into the esophagus at about 30 centimeters. So either enter after that area or enter before that area, because the entry is the more difficult than maintaining and dissecting a tunnel. In the entry, you may just make a nick too deep and then get tamponade. If you start the tunnel above the pericardium, and then by the time you reach the pericardium, you have an established nice submucosa, nice tunnel, I don't think you're going to get into the pericardium. And then for the myotomy, as I said, we all are going into short myotomies now, 5, 6, 7. You can start the myotomy after the pericardial sac covering the left atrium.
Okay, so but anyway, your take-home message is just go posterior. It's a safer space. Is that correct?
Right.
And you don't think that technically is more demanding, is similar?
I think it's easier posteriorly.
Okay.
Again, if the anatomy is usual, in some sigmoid patients, you find like the posterior wall dives so deep that it would be very difficult to dive all the way down there and then ascend doing a tunnel. So you may need to start proximally anteriorly. So it depends on the anatomy. But for regular patients, stage 1, stage 2, type 1, type 2, without sigmoidization, I think posterior is easier than anterior. It's definitely faster in 3 out of the 4 studies in the meta-analysis. And the meta-analysis did show, higher injuries anteriorly to the mucosa. The Chinese study also showed more AFib, cardiac arrhythmias. didn't reach statistical significance, but more anteriorly than posteriorly, which makes sense. So yeah, posterior I think is easier in the usual uncomplicated anatomy. I think it's easier and faster posterior, and definitely less risk of getting into any cardiac complications.
And also final clipping is easier, probably, no?
Yes. The meta-analysis showed that the closure was statistically significantly faster posteriorly.
Okay, good. So last point to John. John, what is your suggestion to get trained in poem, at least in your country? How is the process? You should go observing animal. So what do you use to train people with your Erbe technology to have them ready to go for poem in patients?
Well, we assist. I mean, it's a great question, right? And it's something that we take very seriously in the United States, and especially from an Erbe perspective. So we assist physicians like Dr. Stavropoulos and out west, Dr. DeMeester and that team where Lee Swanstrom used to be. He's now in Europe, but they have a poem course at least twice a year. Dr. Stavropoulos has visiting people, I think, don't you, Stavros, still coming into Winthrop, but we spend a lot of time.
Yeah, we're like one-on-one preceptorships.
Yeah. And we spend a lot of time doing explant labs. I mean, I do explant labs with Stavros' fellows before they graduate. We spend a lot of time. I'll tell you, the question you had just asked Dr. Stavropoulos in regards to into serious adverse events, maybe a little less serious, but potentially very serious. We train the staff to get very involved in these procedures. Belly feels, baseline belly feels every 5 minutes, looking at peak airway pressures on the anesthesia machine, helping identify large vascular structures preemptively before they get cooked. And I think that with more and more sites coming on board, I should say centers that are doing POEM, it's imperative to teach about thermal insult. It's actually thermal insult. When you're coming out of the tunnel, for instance, in POEM, and going down the normal esophageal lumen, to carefully inspect the esophageal mucosa and make sure that if there's a white mark that doesn't, that's not through and through, it's not a hole, but a white mark that doesn't wash off or scrape off, it's important to clip it, because there's a high chance that it might be thermal insult. And I personally know of thermal insult that doesn't declare itself until 3 days after the barium swallow, the second day, the day after the procedure.
Yeah, John, you're right. But my concern sometimes when you see this whitish area, you try to clip just after you have closed the tunnel, because it's still too fragile and there is no tissue behind, so the muscle is being cut in the middle. It's important to use the right technical clip. You need to be much more gentle than in other situations. So you should not apply a lot of force. You need to be gentle, suck gently inside and clip, because you're clipping mucosa to mucosa. There is no submucosa has been tunneled, there is no muscle. So if you do this, try to use a different approach as a standard clipping technique. Stavros, do you agree on that?
100%. It's always a question with the white ones.
Yeah.
Will you do more damage trying to clip it or not?
Here's what I'll say. When it's white, there's it's thermal. It's irreversible thermal insult. It's greater than 49.
But the question is the depth. No, but John, the question is the depth. What's the depth? Because I can tell you how this can happen. If you use spray in the submucosa and the mucosa is touching the mucosa on the opposite wall of the esophagus, it creates a high or a conducting zone between the two touching mucosas with a little bit of fluid in between. So the spray current really jumps without delivering any energy through the tunnel covering the submucosa and the mucosa, and then delivers energy in this maybe high resistance area where the mucosa of the tunnel is touching the mucosa on the opposite wall of the esophagus with a little fluid in between. I've seen it where there's no injury from inside, but there's this white spot because the two mucosas were touching and created a place where the 4,000 volts could not pass without leaving some thermal energy, probably because the resistance was high and some of the energy became thermal there. So it may not be deep. And if you try to put a clip and the clip digs into the tunnel and you can see it from inside now, and now it's a full thickness, it can get a little scary. Of course, then you can inject some fibrin glue or do something non-specific like that.
That's a point well
Okay,
taken.
good guys. I think we are a little bit over time, but there was a very interesting talk, very, very interesting discussion. So, John, I want to be very provocative. Probably we need to organize a Stavropoulos Endoscopy On Air next time, having him live, doing a procedure, following him, and just getting all these tips and tricks that are extremely important. I learned a lot. Thanks, Stavros. Always pleasure to be, I would say, trained by person like you. We have been all together in Shanghai, had a lovely time, but I think it's very nice also to have you teaching us on live procedures. So my proposal to Erbe, tonight I have a dinner with the big bosses of Erbe. They are down here in Milano. My proposal will be, please let me organize a live procedure, live endoscopy on air, Stavros based. So John, of course you will support me as well, please.
Of course.
So thank you guys. It's been a pleasure, and I hope to see you very soon in person because I'm missing both of you, missing dinner with you. Thank you guys.
Miss you.
Thank you. Too, Ala. Thank you. Bye.